Started. Thank you so much, everyone, for joining us for the September edition of our Children's and Women's Research Lunch and Learn session, jointly hosted by the BC Children's Hospital Research Institute and the Women's Health Research Institute. Today, we have three really exciting presentations, really focus on navigating research services, tools, technologies, and facilities at the Oak Street campus. We're first going to hear about the Living Lab at Home, followed by the Prime Center, and then the PHSA Research Nurse Roles and Services. So we'll give introductions to each of the teams before they present, and we'll just hold questions until the very end of all of the presentations. Before we go ahead and get started, we'd like to just gratefully acknowledge that our work at the Research Institutes is located on the unceded, traditional, and occupied lands of the Coast Salish peoples, specifically the Musqueam, Squamish, and Tsleil-Waututh nations. And we're very grateful for the opportunity to live, play, and learn on these lands. I'm going to turn it over to Dr. Katelynn Boerner to get us started with the Living Lab at Home presentation. Dr. Boerner is an assistant professor in the Division of Developmental Pediatrics at UBC. She's an investigator at the BC Children's Hospital Research Institute and also provides care as a registered psychologist with the Complex Pain Service at BC Children's Hospital. Katelynn's research focuses on making pain research and care more accessible and equitable for families, and she has a particular interest in supporting gender diverse and neurodiverse young people. In addition to her work, Katelynn is also an amateur pianist, which I just found out about, a fair weather runner, a proud mom of a kindergartner, and she is always on the hunt for amazing coffee. So we'll turn things over to Katelynn.
Thanks so much, Shanley. And you may have guessed from that bio that I did not go for a run this morning. Anybody who's in Vancouver right now will know this is the beginning of the end. But very happy to be sharing with you today a bit about the Living Lab at Home. This is an initiative that I co-lead with Dr. Tim Oberlander, and that started during my postdoc with him. It's really been a team effort. Some of the folks who've been involved are listed on this slide here, but many folks across Oak Street campus are very deeply involved in this work. And thank you, Shanley, for that lovely land acknowledgement. And I think, part of the guiding vision behind the Living Lab at Home was to try and make research more accessible and equitable to young people who live across BC and Yukon. And I think, inherent to any health equity work is really thinking deeply about the need to change how we do things, to move away from colonial structures and to think more flexibly about what families and the patients we have the privilege to serve may benefit from, engaging them in that conversation. So the Living Lab at Home was born out of some frustration, really, in this really big translational gap between what we see in research and what happens in clinical practice in real life. And one of the big drivers of that gap is the fact that a lot of our research is conducted in settings that don't really resemble real life for young people. So if we think about the image on the left here representing a maybe traditional clinic or research environment, it looks nothing like the spaces that children, youth, and families and live, work, and play in. And so our idea with developing the Living Lab at Home was trying to take research out of the lab and into the community, hoping that this would not only get us more ecologically valid data, but also be able to capture some more meaningful aspects of child and family health research. So we are looking at methods that allow for more ambulatory data collection, rather than relying on questionnaires that might be subject to recall bias. We've been looking at ways of trying to have more point-in-time measurements, so measurements that can occur as things are actually happening, moving away from single time point data collection to more micro longitudinal and dynamic data capture, and working in pediatric chronic pain. This is particularly important for the patients that I have the privilege to work with, where pain is not a static thing. It fluctuates throughout time, and that's something that hasn't always been captured in our traditional research methods. The Living Lab has also attempted to capture multimodality methods of data collection, and as I mentioned, data collection where people actually live. So the way that we've gone about developing the Living Lab is sort of like a framework or a toolkit, was starting off with family engagement, updating our methods based on family feedback, doing some pilot and accessibility studies, again, updating methods based on feedback, and then using this pilot data to apply for funding for research studies that could then embed some of the Living Lab at Home methods within them, but then continually kind of taking this principle of iteration and ongoing feedback and updating of our methods to try and keep that cycle going. So I'll just briefly walk through how we came to the place where we are now. We have initially received some funding from the Brain Behavior and Development theme to do our initial phases of the Living Lab. And we started off by doing patient engagement work with families from across the developmental spectrum with a variety of developmental, medical, and psychiatric needs and complexities. And we asked families about what they would need to be in place to allow in-home data collection to work for them. And we gave them 3 examples of types of data collection. So ecological momentary assessment, which is filling out questionnaires on a smartphone a couple times a day over the course of a couple weeks. We also asked them about how they would feel about wearing an activity monitor, so an accelerometer that would measure both physical activity and sleep. And we also asked them about collection of biological samples, and specifically salivary cortisol data. And the reason we chose those 3 methods as examples to kind of ground and situate ourselves in these conversations with families is that they represent a variety of modalities and types of data collection with different levels of family involvement. So self-report is very family driven. And things like the accelerometer is a bit more of a passive method of data collection. And what we heard from families through the qualitative analysis of the interviews that we conducted was that families really asked for flexibility in the research methods, and said a lot of the reasons they hadn't been able to participate in research before was because of inflexible protocols. The families really wanted a reciprocal relationship with the research team, so they wanted to be able to inform the study methods, but also to be able to see and interact with their own data, so that they could benefit from better understanding their own health conditions. And that having the opportunity to have a more flexible protocol and to engage in this reciprocal relationship with the research team would allow for opportunities to participate in research that had not been previously accessible to them. And families gave a lot of really specific feedback, as well as some kind of overarching themes about what would be helpful for them in attaining this. So then we took all of the feedback we heard from families, right down from the nitty gritty of, like my child won't wear an accelerometer if the strap isn't comfortable for them, up to kind of bigger picture themes around how do we make data collection trauma informed. And we incorporated all of this into our methods that we tested out in a feasibility and accessibility pilot study. So this was just recently accepted in the Journal of Developmental and Behavioral Pediatrics, where we describe a sample of 16 youth who underwent feasibility and acceptability testing of those 3 methods that we described, but with adaptations in place that were informed by our patient engagement. So we had some pre-registered benchmarks of what we would have considered to be kind of feasible and acceptable to move on to future research projects. And then we collected data over the course of 14 days. Saliva collection was just for the first 8 days, but the ecological momentary assessment and the accelerometer was done for 14 days. And then we had exit interviews at the end to ask families about their experiences of using these methods and to give us some more feedback to iterate on. And I'll just show very quickly some adherence data. What you'll see from this is that adherence was relatively high for the accelerometer and the ecological momentary assessment. So, the green is where we received all the data that we had asked for kind of across all the time points. And across all three modalities, adherence to the data collection protocol decreased over time. And particularly problematic was the saliva samples. This was the most rigid protocol of the three. It was hard for us to implement the flexibility that families wanted because of the time points that this and how the saliva needs to be measured to be able to do a cortisol analysis. And I think sort of as we might have expected, that was the one that had the most trouble with adherence. And from those qualitative interviews that we conducted at the end of the study, families told us that the research question was really important for their engagement in a study like this. And because it was a pilot feasibility and acceptability study, not all families really saw this as being as meaningful a research question for them as it would have been if the methods were being used to answer a question that, say, may inform their child's treatment. So this was really important, I think, for anybody who's doing feasibility studies to consider. Families really said, you know, if you were answering a question that was more meaningful to us, we might have tried a little bit harder to get all the data points you were asking for. As we might have expected, data collection was not a passive or neutral experience, both positive or negative. So some families found a benefit of collecting their data, but also some small issues that families had, either with the wording of a question, confusion about an aspect of the protocol, could really become magnified when they were asked to do that method multiple times over the course of the week. Families really appreciated any opportunity that we allowed for flexibility and personalized approaches. And also our data collection experience really highlighted the fact that collecting data around context and what's going on for the family at the time of data collection is super important because real life happens. An example is one of our participants was hospitalized during their data collection period, and having that information was really important for interpreting the data that we got back. And finally, talking about is different from doing. So some of the things that families had asked for in our phase 1 engagement interviews actually didn't end up being things that they wanted or needed when they actually did data collection. So I think this really highlights the need for this continued iteration and continued engagement with families to learn more about how we can continue to make our methods more accessible and which aspects of having a flexible protocol families actually benefit from. So we've been continuing to update our methods based on feedback, and this is just an example of some of the types of feedback that we've gotten that we've been incorporating into our methodology and that we're able to then share with other research teams who are interested in using these methods. And as you'll see here, you know, this is really again, from like nitty gritty things about like making sure that the accelerometer is waterproof and that the device can fit around small wrists and there's different strap options for sensory needs, all the way up to, you know, thinking about, you know, trauma-informed methods of data collection and how do we not contribute to harms in the family by repeatedly asking them about things that are challenging. And we also calculated and collected a lot of data around sort of how much it costs and the logistics of doing this type of in-community or in-home data collection, which then can inform other research teams that are interested in using these methods or applying for funding. And so I'll just wrap up by giving a very large scale overview of how we've been implementing the Living Lab at Home in different projects and how we've been using this as an opportunity to collect data from different populations and continue to iterate and kind of update our methods. So this just shows all of the current either applications for funding or ongoing projects that are using the Living Lab at Home methods to answer a variety of questions. The funding sources are listed along the sides, but you'll see we've partnered with a bunch of different PIs from across Oak Street and beyond to look at using Living Lab at Home methods to evaluate clinical interventions, using the data collection itself as an intervention, applications sort of beyond children and youth, but looking at perinatal mental health, and also looking at it. So this is specific to my program of research in pain, but looking at increase in the accessibility of pain research across the developmental spectrum. And we're always really excited to hear from teams who would be interested in using some of these methods or exploring other methods for community-based data collection. And so I would really encourage you to reach out if you have any interest in partnering on a living lab project. Thank you.
Amazing. Thank you so much, Dr. Boerner. Like I mentioned, we'll wait to hold questions for each of the presentations until the end, but that was such a wonderful overview of the Living Lab at Home. And yes, like Katelynn said, please reach out to her if you have any interest. Okay, we're going to turn things over to Maryam and Tiffany. So I'd like to introduce Maryam Yasinian. Did I get that right? Maryam is a research coordinator with the Women's Health Research Institute and supports the Prime Center as part of her portfolio. And co-presenting with Maryam today is Tiffany Reeve. Tiffany is a very busy research manager with UBC supporting the stimulus study, which is one of the projects being run out of the Prime Center. So we'll turn it over to the both of you.
Thank you so much, Shanley. I hope that you can see my screen.
Yes, we can.
Perfect. Okay. On that note, hi, everybody. Welcome to this presentation. My name is Maryam Yasinian, and I'm the Prime Research Coordinator. I'd like to start by acknowledging that I am joining you today from the ancestral and unceded territories of the Coast Salish peoples, which includes the Musqueam, Squamish, and Tsleil-Waututh peoples. As Prime Team, we are grateful to live and work on this land, and to gather here with you today. I'm very happy to present the Prime Center on behalf of our team. I'll start by giving you an overview of what Prime offers, and then I will pass it over to my colleague Tiffany, who will share more about the stimulus research study as an example of how Prime supports research in practice. Prime was a dream, and now it is a dream come true. It was the vision of creating the first ultrasound research and education hub in BC. And today, we have it right here at BC Women's Hospital. What we do at the Prime Center is that we support imaging research and education by providing dedicated rooms and advanced ultrasound equipment, including our simulation tools. What makes Prime special is that how it brings together researchers, educators, and learners from a wide range of disciplines to conduct research, share ideas, and bring in new people. Prime was made possible thanks to Dr. Denise Pugash, a radiologist in the ultrasound department, who secured a Canadian Foundation for Innovation grant back in 2015. That's what really set things in motion for creation of Prime. Now, let's take a tour of the Prime Center to just give you a better sense of the space and the equipment that we have available. Just going to mute this. So you are seeing the patient waiting area. Here is our imaging suite. We have 4 imaging rooms. This is our venipuncture room. Dry lab space, sorry, it's our second imaging suite. Here is our dry lab space for researchers, our collaboration room, another imaging suite, our simulation room, and finally, our patient consent area or patient consent room. As you saw, Prime is equipped with various specialized rooms and spaces. I just want to add that we also have a sterile processing room where medical instruments and medical equipment are just disinfected or cleaned. We didn't have that part in our virtual tour. On that note, in this slide, you can see some of the equipment we use at Prime, including ultrasound machines, portable units, and other specialized tools. All these Prime facilities support a wide range of applications, as you can see here on this slide, including obstetrics and gynecology, fetal echocardiograms, pediatrics, neonatal care, 3D and 4D ultrasound imaging, research interface mode, and of course, much more. Speaking of Prime equipment application, I'd like to share a video from my colleague, Amanda Easton. She couldn't be here with us today, but recorded this video to show us how some of the equipment is used in various practices at the Prime. So let's listen to Amanda.
Greetings to our Lunch and Learn guests. Today, I'm here at the Prime Center with Amanda, our senior sonographer specialist, who will walk us through the key features of the Prime equipment. So let's get started with Amanda.
Thank you, Maryam. So at the Prime Center, we're equipped with some of the most advanced ultrasound systems, allowing us to push the boundaries of research in maternal, fetal, and general health. Our Voluson E10 offers incredibly fast and detailed imaging, making it essential for complex obstetrics and gynecology cases. Its advanced capabilities allow us to diagnose and monitor conditions with unmatched precision, particularly in fetal echo and fetal vascular studies. My favorite transducers on this machine are the C29 and the RM7C, which is this 3D probe. The C29 has crisp color Doppler and a reasonably small footprint. That's this lens here. And a low frequency range, so it's really versatile, a really versatile transducer. We consider it to be a workhorse transducer in obstetrics, but it can also be used in pediatric and adult studies. Okay, now we're in front of the Philips Epica lead. We have two Philips Epica leads, and they have a very sophisticated design, and it's a nice, simple control board. It's paired with innovative technologies that ensure that we capture clear, high-quality images, even for the most technically challenging cases. This system was and still is pivotal in areas such as neonatal head and pediatric care, and it gives us detailed insights into difficult-to-scan anatomy. So my favorite transducer is the on the Philips is the EL184. It's a very broadband transducer that can be used for the types of near field imaging like neonatal head, and for deeper penetration that's required for fetal heads. This one is really, it has really beautiful vascular imaging as well. So the color Doppler is gorgeous. We also have this one's one of my other favorites is a very small footprint lens transducer. It's the MC12-3, and this particular one is generally used for pediatric imaging. It can be used for other studies, but this particular transducer has 30% more depth penetration than typical pediatric transducers. So it's very useful in the pediatric population with a larger body habitus. Right, so in addition to our imaging systems, we use two advanced simulators to enhance our research and education capabilities. The CA Vimedics, which is this one, is a simulator that is mannequin-based, and it features what we call an augmented reality on the left side, so it's good for people without ultrasound background, and it also has an animated ultrasound image on the other side. It allows the users to practice image optimization and assess fetal anatomy and perform endovaginal and transabdominal imaging in a simulated, relaxed environment.
Okay, Kudos to Amanda for sharing those great insights. And now moving to Prime team, some of the people behind Prime efforts. Finally, we also have a website where you can find more detailed information. So feel free to visit our website, explore more, or email me if you have any questions. Now, for the second part of our presentation, I'll hand it over to my colleague Tiffany, the research manager for the stimulus research study being conducted at the Prime. She will showcase the study as well as just as an example of how Prime supports research in practice.
Thanks, Maryam. So stimulus stands for stillbirth risk identification using multiparametric ultrasound. It's a bit of a mouthful. That's why it has the acronym stimulus. You can go to the next slide. I'll just breeze through this pretty quickly and provide a really high overview because I know there's just a few minutes here at the end of Maryam's presentation. But so Stimulus is funded by Welcome Leap, which is a global charitable organization that funds what they like to call high risk, high reward research. We're part of the In Utero program, and the focus of the In Utero program is stillbirth. And the goal is to reduce rates of stillbirth in half globally within a 3-year timeframe. So it's an incredibly ambitious program that we're a part of. And so stimulus, the primary outcome for stimulus is perinatal hypoxia, which is an inadequate supply to or utilization of oxygen by the fetus. It's typically diagnosed at or around delivery and can lead to serious medical complications, including encephalopathy and ultimately stillbirth. So the aim for stimulus is to predict perinatal hypoxia using quantitative ultrasound from the placenta, which we call QUSP, and I'll explain in a second what quantitative ultrasound actually is. And we're capturing this between 35 weeks gestation and delivery. And so the hope is that we'll have the ability to, with this research, to identify perinatal hypoxia early in gestation, and that will hopefully allow for some additional monitoring as well as efforts to prepare for more immediate intervention if that's necessary. So what that we think might look like is perhaps there's a resuscitation team in the delivery suite ready to go if we know that a baby's going to be hypoxic, and that could potentially save some precious moments. You can go to the next slide. So Stimulus is a multi-center study. We have sites collecting this QUSP data for us from around the world. We have most of the sites are in the UK, but we also have one in Australia. We have a site in Uganda, and then also in the US in Washington. Our sample has been a little bit all over the place, but we're aiming for a total of 710 in total. And we have about 250 at the moment recruited for Stimulus here at Women's. Our recruitment partners are South Community Birth Program, which is a maternity care program in the community. And then we also have Emma and fetal monitoring clinics at BC Women's who are we're recruiting through. And then we have MFM nurses who are handing out recruitment flyers for us as well. We're scanning between 35 and 37 weeks gestation for Stimulus. And that's a really interesting time point for women because we've found that most don't have the opportunity to have a scan at that point in their gestation, so that close to delivery. And so that's actually quite motivating for our participants. They really want to participate in Stimulus because they get the opportunity to have that scan. Like Maryam said, all of our scans take place in Prime, and they're all completed by BC Women's Hospital sonographers. And then we have a harmonized data set that's part of the In Utero program. So all the teams participating are collecting the same clinical variables. And so we're pulling that clinical data from our participants' charts in Cerner. You can go to the next slide. So what is QUS, or I should say QUSP? And I should also mention that So in addition to QUSP data, we also collect biometry data using the GE, which is in Prime. But in terms of QUS data, so what we do is we scan our third trimester placenta using a handheld scanner that's called Clarius. And so unlike many cart-based ultrasound systems like GE or Philips or these more expensive ultrasound systems that are at Women's, Clarius allows us to get access to the raw radio frequency data that's essentially behind an ultrasound image. So these other software programs don't allow you to kind of get into that as researchers. So we use the Clarius scanner and we pull out we call it RF data. We pull out the RF data, some fancy normalization and calibration happens that I won't pretend to know very much about. And then we end up with these 3 quantitative ultrasound parameters that are really important to us. And those are attenuation coefficient, backscatter coefficient, and scatterer diameter. And so these 3 QUS parameters allow us to quantify the tissue health in the placenta. So they give us a bit of an idea of the microstructure in the placenta. And then we use these 3 parameters, we plug them into our model, and that in order to allow us to predict the risk of perinatal hypoxia before delivery. So you can go to the next slide. So Maryam asked me to collect a few participant quotes. We chose a random sample to make the request to, but obviously this is going to be a little bit biased because I think the people that were most pleased with their experience are the ones that responded. So I'll just quickly go through these quotes. I absolutely love my stimulus experience and have already recommended my pregnant friend to try and join. The extra ultrasounds offer so much peace of mind and bonus scan pics, and the staff are always so kind and friendly. I like the thought of my pregnancy and placenta being of some benefit to research. And then I was happy to participate in research and increase knowledge in this area. Everyone working on stimulus who I interacted with was very professional and welcoming. The ultrasounds were very detailed. And then the last one, having experienced a late pregnancy loss before, I was honored to be offered the opportunity to be involved in the stimulus study. If this research results in less pregnancy losses and even one less stillbirth, it will be so worth it. The research team was incredibly friendly, understanding, and supportive, and worked hard to make sure my data could be included in the study. I'm so grateful for this research opportunity and look forward to seeing the results published. And that's it.
Thank you so much, Tiffany. And thank you so much, everyone. I hand it over to Shanley. Yeah, just to stop sharing, sorry.
Thanks so much, Maryam and Tiffany. That was a great overview of the Prime Center and some of the research that can be run out of there. Okay, last but not least on our research services presentations, we have the PHSA research nurse roles and services. So we have Erin, Hemmerling, and Alice Van Zanten co-presenting today. Both Erin and Alice are registered nurses on the newly formed Nursing Resource Research Team at Children's and Women's. Erin has been working at BC Children's Hospital for just over a year now and is excited to transition into the research side of nursing. And Alice recently returned from living and working in Melbourne, Australia. Previously, Alice worked in the NICU at BC Women's Hospital, so you might recognize her as she's worked on a number of different research studies in the NICU over the years. So I'll turn it over to you both.
Okay, can everybody see the screens?
Sorry, I meant to mute you. I meant to mute myself, but I muted you. We can see your presenter view, Erin.
Oh, okay. How's this one?
That looks great.
Beautiful. Okay, so very interesting presentations. It's so cool to learn what we're doing here. Very, very interesting. We're going to keep this one just short and sweet, just a little introduction. Like Shanley said, we are the Nursing Resource Research Team. So we also like to acknowledge that with respect the unceded traditional territories of the Coast Salish peoples, including the Musqueam, Tsleil-Waututh, and the Squamish nations, which we have the privilege to live, work, and play. And even on a rainy day like today, it's still a wonderful place to be. So NRRT, who are we and what do we do? So my name is Erin. Like Shanley said, I have been at BC Children's with the nursing resource team, kind of the float team for the inpatient side of things for the last year. I'm brand new to research, so this has been a nice big learning curve for me, but I'm loving it so far. Pass it over to Alice.
So I started my career at BC Women's NICU back in 2007. I've also worked at Surrey Memorial NICU, and I was introduced to research in my role in the NICU, and I've worked on a number of different NICU research studies in the past. But I'm really excited to start working with the clinical trials Super Hub.
Yes. So what is it that we can do for your study teams? So we'll be able to provide any nursing duties that are required in your studies. So this includes things like the assessments like vitals, height and weight, medication administration, and then monitoring after we administer meds. We can do any medications except for IV infusions. Any IV infusions that are needed for studies are currently going to be done through the medical day unit. So we can help direct you to those services if that's what you require. But otherwise, like oral medication, sub-Q, intranasal, all of that we can do. We can perform ECGs. We can also perform phlebotomy, which is nice with this role. One of the new things that we get to do is that we can take both research blood draws as well as clinical blood draws in just one poke. So ultimately, this is better for the participants, more patient-centered care, less trauma with the needles. So that's a nice skill that we can do. Any other specimen collections that are required for the studies, of course, the data entry. And also this is a brand new service, so we are very open to your feedback. We're here to help you. So if our services need to be expanded in the future, please let us know. Currently, our hours of operation are Tuesdays, Wednesdays, and Thursdays. You can book our services between 10 a.m. and 6:30 p.m. And then on Fridays and Saturdays, you can book our services between 11:30 a.m. and 8 p.m. How to access our services. So first and foremost, any PUFs that are required, the program utilization forms, and if there's any other program approvals that are required, those have to be submitted and approved, just so that we know that the services or the areas that we'll be going into will allow us to be going into those. So that's the very first thing that study teams need to obtain. After that, study teams can complete a research support request form on REDCap. So I don't have access to the chat anymore, but I can throw in a link into the chat. I believe that Jennifer is also on this call, but I think the link should be provided in many places. But that is like a pretty in-depth form where you'll just kind of outline what your study looks like, what services need to be required, upload any forms that are included with that. And then we have a shared research email that is researchnurse@cw.bc.ca. And once that form has been submitted, then we will get an alert that and we have a new study request. Depending on who's working the day of, either Alice or myself will assign ourselves to the study. We will go through and we will either conditionally approve the request, or if we have any outstanding questions that need clarification, we will set up a meeting time to go over that with the study teams. And then we will draft an internal agreement, which needs to be sent to the PI for signature. This one can't be delegated, so it has to go back to the PI and then come back to us. Throughout that process, we also want to highlight that you don't need to necessarily have REB approval or the CST build done before you request our services, because we know those things can kind of take months at a time and we don't want to delay the process. So we encourage you to apply for our services beforehand. As long as we have the PUFs and program approvals, we can get going with that. And then that way too, we can kind of help your teams navigate if there's any areas of clarification, anything else that's needed. And then once all of the requirements have been met, then we can sign off and we can officially hit go, and you guys can book our services through our shared calendar, again at the researchnurse@cw.bc.ca. And so that will just involve the teams finding a time when we are free and not with other studies, booking a room, and then we will show up at the time and date and perform whatever it is that your study needs. So just some general information regarding fees. So our fees are offered on a cost recovery basis. So right now that's $70 for the grant funding and $85 an hour for institutional funding. Also want to note that there's no study setup fees for us, but there is going to be training time included, just so that we are both on the same page and we know exactly what to do. So the training time is kind of in lieu of that. Like I said, the study coordinators, they're responsible for booking the rooms for any sort of meetings or participant appointments. And so we know where to go and when to be there. We'll also have access to a cell phone, just Wi-Fi based cell phone. So for any emergent issues, whether that's a cancellation or if there's studies that are happening in the emergency department where we can't really pre-book those schedules, you can contact us through the Teams, Microsoft Teams messaging through the cell phone. And so we'll always have that with us, and then we can respond and plan times and locations to meet through that. We would also like to note that the study teams are responsible for providing us with things like the blood collection tubes, med supplies. And then I was told that crew does not stock snacks and juices for participants. So that's always nice after a blood draw to provide that. Also, like I mentioned earlier, we would love your feedback. This is brand new. We want to tailor this service to be the most effective for everyone. So through REDCap, in the same area where you will request our services and fill out that form, there's also a missed opportunities survey. So if your teams ever require an appointment with one of us on one of the days that we're not working, or if we've already been pre-booked, or if something just happens where we were not able to make that appointment, you can fill out that survey and it gets back to us. But also if there's just any general information that you guys would like to share with us, feel free to send it to our research nurse email or to CSRU support at bcchr.ca. Because we are very open to being flexible and adapting. That's all that we have for right now. I'll just stop here and try to grab that link. Oh yes, Jennifer did add it. Okay, wonderful.
Yeah, Jennifer's got it. Thanks so much, Erin and Alice. That's such a great overview of these new services. I know there will probably be lots of folks really interested in speaking with you after this, given it's a new program and new service. There was one question in the Q&A that Maryam's already answered. So the question was, what does 4D mean? And Maryam already replied saying it's a technology that provides 4 dimensions, which captures dynamic visualizations. They're really cool images. You can actually Google 4D ultrasound and see like the full fetus. It's really really interesting technology. So feel free to get in touch with Maryam if you have more questions about that. Mel has popped a question in the chat for Erin and Alice saying, should that read as $85 an hour for industry funding, or what qualifies as institutional funding? I think, yes, I can't remember if the slide accidentally said institutional, but it would be industry funding. Is that right, Erin and Alice? Yes. So for like industry funded trials. Thanks, Mel. Are there any other questions? Oh, Sarah has her hand up, so I'm going to unmute you, Sarah. Am I able to unmute you? Can you talk?
Hi, can you hear me?
Yes, we can hear you.
Perfect. Thank you so much for the wonderful overview of the new Research Nurse Support Program. I'm very excited, and I'm actually just working on the application form. I have few questions. So one is there are for one of the specific studies that we are hoping to have support from the research nurses. There is measurements that may not be usual tasks that the nurses are doing, such as fetal heart rate monitoring, and the sponsor is sending the device and offering the training. Is this something that the research nurses would do? And a second question that I have is, so for one of the studies, when we have the patient in, then automatically we are going to populate all the appointments for about 30 weeks that they are coming at the same day, same time. And then we will need research nurse support for those appointments. Can we book all of those in advance? Thank you.
That's a great question, Sarah. So you can definitely book our services in advance through the calendar, as long as we're free during that time. Book as many as you need us for. I think Jennifer will have to clarify that, but I believe if we're going to be provided with the training, we should be able to do any sort of measurements, monitoring using the equipment, as long as we have adequate training.
If it's a question of our scope, that's going to be something that we'll have a meeting with you about and clarify the training.
Wonderful, thank you.
You're welcome.
It might also, I'll just add, Sarah, it might also be a question for the sponsor. If the sponsor is okay with registered nurses receiving the training, if they can do that, then yes, then Erin should be able to provide that service.
Yeah, we already have approval from a sponsor for that. They are happy for research nurses to do it. We just wanted to make sure we have agreement on this side as well.
Absolutely. Thank you. Great questions. Any other questions? Katelynn or Maryam, Tiffany, Erin or Alice? I'm just going to pause and make sure there's nothing being quickly scrambled written in the Q&A or in the chat. Okay, well, if that is everything, thank you so much, everyone. As mentioned previously, all of these Lunch and Learns are recorded, so feel free to access them on the Hub and through the WHRI's YouTube site. If you have any follow-up questions for Katelynn or Maryam and Tiffany or Erin and Alice about the services that they discussed today, please feel free. You can contact me, the CRSU, or any of them directly. Thank you so much. We'll give you back 10 minutes of your Wednesday. Have a great day, everyone.